Our first speaker this morning is Dr. Meghan Cooper. Dr. Cooper is an associate professor of pediatrics at Washington University in St. Louis and director of clinical immunology and the Jeffrey Modell Diagnostic and Research Center for Primary Immunodeficiencies at St. Louis Children's Hospital. She cares for patients in pediatric rheumatology and immunology clinics with a clinical interest in immune dysregulation. Dr. Cooper's laboratory focuses on basic mechanisms of immune cell activation and regulation. She investigates defects of the immune system that lead to pediatric autoimmunity and immune deficiency, using genetic sequencing to uncover novel molecular mechanisms of pediatric disease. Her lab also studies mechanisms of NK cell activation, including long-term priming of NK cells for memory functions. Dr. Cooper has an interest in education of physician scientists and serves as an associate director of the Medical Scientist Training Program at Washington University. Please join me in welcoming Dr. Cooper.
All right, thank you, and thank you so much for the invitation to speak here. It's been a great meeting, and it's fun to be here in Hershey, Pennsylvania. So I am going to talk about rheumatology in the AI clinic today. Here are my disclosures. I won't be discussing any products related to this. I will say that pretty much as a pediatric rheumatologist and immune deficiency physician, every treatment that I talk about is going to be off-label for the most part, so just keep that in mind. Here's the learning objectives for this talk. So I'm going to start with a couple of cases. So the first case, this is a nice published case from another group from 2011. So this was a 13-year-old girl who had had chronic urticaria, and you can see the picture here that they had put in this publication. It had been going on for about 2 months. There was itching. It looked like chronic urticaria. They had done some laboratory workup that looked fairly normal, though she did have an ANA of 1 to 160. She responded well, but then 2 years later, she had recurrence of the urticaria, and this time she also had oral ulcers. And at that point, she actually got diagnosed with lupus. And additional laboratory work supporting that diagnosis included lupus anticoagulant and other autoantibodies that were present. So this is a question that, as a rheumatologist, I know I'm talking to my allergy colleagues, I'll frequently get about when to test for lupus in these patients with chronic urticaria. And I took a look at the literature, and there are a couple of actually pretty nice large studies that have looked at patients with chronic urticaria and what is the actual incidence of lupus. And this first one at the top here was a pediatric focused study that looked at 852 patients in Brazil. And really in that large cohort of patients with chronic urticaria, there was only about a 1% incidence of patients that had lupus. In those patients that did have lupus, they had the chronic urticaria for quite a while, 190 days. In this one on the bottom here, published in JACI in 2012, they looked at over 12,000 patients in Israel with chronic urticaria, and only 0.4% of that cohort actually had lupus. And most of the patients had urticaria after their diagnosis of lupus. So only 15% of those patients actually had urticaria before their diagnosis of lupus. And so if you're thinking about autoimmunity and urticaria, what else should you be thinking about? And much more common than lupus were hypothyroidism, about 10% of the patients, hyperthyroidism, rheumatoid arthritis, type 1 diabetes, Sjogren's syndrome, and celiac disease. So definitely there is an association with chronic urticaria and autoimmunity. Some of the things listed here might be a little bit more common than lupus, though. Here's another case. This was a case published by colleagues at University of Chicago. This was a 3-year-old who had presented with arthritis. She had polyarticular arthritis, so involving more than 4 joints. She had arthritis in her knees and ankles. She had disease for several years despite standard therapy, so methotrexate, anti-TNF therapy. And then at age 6, started having fevers, had splenomegaly, had autoimmune cytopenias, so autoimmune hemolytic anemia, autoimmune neutropenia. There was actually concern for macrophage activation syndrome. So typically our patients with polyarticular arthritis, our kids don't get macrophage activation syndrome. It's our kids with systemic arthritis, so the kids who have fevers and rash associated with their arthritis that are at risk for macrophage activation syndrome. She was treated for that, though, because that's certainly what she seemed to have at the time, but had refractory cytopenias despite appropriate therapy. And then at age 9, she developed autoimmune enteritis and the CNS white matter lesions that are shown there. So her diagnosis was LRBA deficiency. And this was diagnosed by genetic testing, so she had compound heterozygous deleterious variants in LRBA. And I'll talk a little bit later as we're talking about arthritis about what this leads to. But she started on targeted therapy, so she started on CTLA-4 IG with improvement, and then sirolimus was also added. But then she eventually went on to hematopoietic stem cell transplant. So this is an example of an inborn error of immunity, so an immune deficiency that's actually masquerading as a rheumatologic disease. Where early diagnosis and getting to the genetic diagnosis can lead to substantial change in treatment, in this case, bone marrow transplant. So today I'm going to talk about kind of these 2 different angles of rheumatology in the AI clinic. So I'm going to first talk about allergy immunology manifestations of relatively common pediatric rheumatologic disease. We'll talk about a couple of different diseases. And then I'm also going to talk about it from the other side of things. So for your patients who have inborn errors of immunity, what type of rheumatologic disease might they have, and how you can be a really good partner with your rheumatology colleagues in being able to treat these patients. I'm going to talk first about systemic lupus erythematosus, as this is probably one of the biggest areas of overlap. And the prevalence in the United States of lupus is about 20 to 50 individuals per 100,000. There is an increased prevalence in individuals of Asian, Black, and Hispanic ethnicities. There's a predominant female. It's anywhere from 7 to 1 to 15 to 1, so lupus is typically a disease of women. However, for children, for those individuals diagnosed prior to age of 9, it's actually pretty similar female to male ratio, so that skewing isn't there. And if you look at all comers, all patients with lupus, about a fifth of them, 20%, present to a physician prior to the age of 16. So, we, probably the most common age that we are diagnosing lupus is around the age of 13, 14, 15, so in these young teenage girls. It's very rare before the age of 5, so if you ever have a patient who is quite young and is diagnosed with lupus, we should really be looking for an immune deficiency in those patients. Sometimes it's going to be something like deficiency in the complement system, which is probably the most common inborn area of immunity that causes lupus. And I'm going to show some pictures here throughout. And so here's the hands of a patient with lupus showing some of that hyperpigmentation. I'd also like to highlight that I'm trying to intentionally show pictures that show individuals who have skin of color, because lupus disproportionately affects those individuals. And it's not images that are always in our textbook. And it's really important to become familiar with how lupus and different rashes look on different types of skin. So clinical symptoms of lupus, I have this here. So there are certainly some physical exam findings and symptoms. So malar rash that I showed you in the beginning, and we'll look at some more pictures of that. They get these mouth sores on their hard palate. So this is a question I'm always asking patients, do you have mouth sores? But I stopped asking, do you have mouth sores? I asked, do you have sores on the roof of your mouth where your tongue touches? Because everybody has mouth sores, right? But for lupus, they're going to get these hard palate ulcers. And so this is one of my patients here with lupus, and you can see that ulcer that she has on her hard palate. They can get vasculitic rashes, and we'll look at some pictures of that. So lupus causes a small vessel vasculitis, so you kind of have to think about where are the small blood vessels and what kind of problems could they cause. So it can cause skin disease like vasculitis. It can cause mesenteric vasculitis, so the small blood vessels around the GI tract. It can cause vasculitis in the brain. It can cause vasculitis in the lungs. So a lot of different organs can be affected. Patients have photosensitivity. So those rashes that I showed you and that we'll be looking at are often photosensitive, so they go out in the sun and the rash gets much worse. They can have non-erosive arthritis. So the patients with lupus tend to have a lot more joint pain. They don't always have as much joint swelling, and the arthritis isn't always as much limited range of motion. It's just really those achy joints. And if you do x-rays, you might not see that erosive disease that you're going to see in like a rheumatoid arthritis or a juvenile arthritis. And they can have CNS disease. So I have here encephalopathy, seizures, and psychosis. But it can really be a wide range of manifestations. So it might even be like if we have a teenager with lupus, somebody who was a straight A student the year before, all of a sudden is falling behind and things like that. So you really need to think about some subtle things with lupus as well. A number of different organs can have involvement in lupus, and I listed some of those here, but nephritis is probably the most important one to watch out for because that is a very common manifestation of lupus and can certainly lead to renal failure. Laboratory studies. Patients with lupus very frequently have cytopenias, and these are immune-mediated. So they'll have hemolytic anemia, they'll be Coombs positive. They often have lymphopenia, so their ALC will be quite low sometimes. Then thrombocytopenia is also relatively common in this population. They have high positive ANAs, and we'll talk about ANAs and when to test and what that means. And then other positive immunoserology, so double-stranded and Smith are some of the most common antibodies that we'll see in lupus patients. Don't forget to check for antiphospholipid antibodies in patients with lupus because they're at risk of clotting. This is just a chart that shows some of the most common clinical features of childhood lupus. And so you see here arthritis, malar rash, headache, nephritis, fatigue. And if you just look at diagnosis and if they ever had it, it's actually pretty similar. So these patients typically when they come in will have multiple different manifestations at the same time. So look at a few pictures of rashes in lupus. So as I said, lupus can cause a small vessel vasculitis, and you can see that in the skin as these non-blanching kind of red rashes. And so this is a very nice example of that in one of our patients here. It can cause, this is an example in the upper left-hand corner of discoid lupus. So you see it almost in some cases can look like a fungal infection or something like that. In the lower right-hand corner is a photosensitive malar rash. This can present many different ways. It can present with hypopigmentation, hyperpigmentation, but typically what you'll see is that it can be on the eyelids, it can be on the cheeks. It tends to spare the nasolabial folds. This is another example of a woman with lupus here from the ACR image bank. And there's a couple of things to point out here. So she's got this hyperpigmentation of her legs. You can see that in various different areas, and so that's kind of a post-inflammatory scarring that's occurring there. You can see in the upper right-hand corner that she's got the alopecia, so we see certainly alopecia in our lupus patients. And then in the lower left-hand corner, you can see some scarring on her hands from prior rash that she had there. So if you are seeing a patient in the AI clinic and you suspect maybe this patient could actually have lupus. What are the labs that you should think about getting? I would definitely start with a CBC. As I mentioned, these patients get a lot of cytopenias. I think an ANA is a good screening test. I tend to only send an A, even in my rheumatology clinic, I'll send an ANA first and then I'll send a saved serum. That's what we can do at our laboratory. So if you have the ability to do that, rather than sending every single autoantibody on the panel, do a targeted look. If the ANA is negative, then you really don't need to send the double-stranded DNA or Smith in most cases. SED rate will be up in patients with lupus. They pretty much almost never have an elevated CRP, interestingly. So this isn't like an IL-6 mediated disease. So CRP is going to be normal. SED rate will be up. If a patient with lupus has an elevated CRP, they probably have an infection. You want to send a urinalysis for nephritis because, in kids, at least a third of those patients, when they present with lupus initially, are going to have nephritis. Sending a UA with micro-macro is good, but also if you can send a spot protein to creatinine ratio, that will give you a good idea of what's going on with their kidneys. IgG, if you happen to get that as part of your workup, is typically elevated in patients with lupus, and we'll actually check IgG periodically in our patients to help to monitor disease activity. Other tests that you could certainly consider based on what's going on with the patient would be something like a chest x-ray, so they get pleuritis. They can get pericardial effusions, so if they have any symptoms of that, you could consider testing. It's a relatively common referral for us in rheumatology clinic to get patients who had an ANA sent for one reason or another, and to kind of ask the question of what is the meaning of a positive ANA. ANAs don't always require follow-up. So this is a couple of different studies that I put together here. On the left is children, in the middle is an international adult cohort, and then on the right is a cohort of 300 individuals in Mexico. But you can look at the ANA titer from being very low, from like 1 to 20 or 1 to 40, up to 1 to 320, and you'll look at the prevalence in healthy individuals, and that's what these numbers are showing. And so for ANAs and the 1 to 160 or lower, what I tend to tell families is, if everyone in your class, these are kids that I'm treating, everyone in your class got this test, about 10% of your friends would have this positive. And without anything else, an ANA of 1 to 160 or below probably doesn't need any other further workup. You can certainly counsel the patients a little bit on signs and symptoms of lupus and, have them return if they're having any of that, but I wouldn't necessarily, that wouldn't trigger any additional laboratory studies. If a patient has an ANA of 1 to 320, then you're starting to get a little bit lower. So you look at the cohort of children on the left there, 700 children, about 5% of them healthy children have an ANA of 1 to 320. So definitely it still might be a red herring, but if they had an ANA of 1 to 320 and anything else, any chest pain, any kind of rashes, other things like that, especially in the right demographic, so a teenage girl, I would certainly do additional evaluation for lupus. So I'm going to switch gears. I'm going to talk a little bit about juvenile dermatomyositis, one of the other diseases that we see relatively commonly in our pediatric rheumatology clinic, and who could certainly be presenting first to an AI physician due to rash. So this is an inflammatory disease of the skin, the muscle, and blood vessels. It is relatively rare in children, and not necessarily rare in our pediatric rheumatology clinic, though. And it is similar to adults with dermatomyositis. It can be quite severe, and prior to the ability to utilize corticosteroids for these children, about a third of the individual children died who had this, and that was due to respiratory weakness. These patients get proximal muscle weakness, so they have weakness of their hip flexors, they have weakness of their proximal arm muscles, and then they get some characteristic rashes. And so I'm showing here one of our patients who has this rash on her eyelids, this kind of violaceous dark purple rash. They can get rash on their hands. We'll look at some pictures of that, and on their extensor surfaces of their elbows and knees. Here's some additional pictures of some of the rashes. So on the left, those are Gottrin's papules, and you'll see in the image on the left, in that individual with light skin, they look kind of red and almost like little warts on the PIPs and the DIPs. And on the right hand side there, the individual with darker skin, it can look like very hyperpigmented skin over those. Again, the PIPs and the DIPs is really where you're going to see it the most. Sometimes you'll see it on the MCPs as well. Some patients will have dilated nail bed capillaries that are visible, and you can see that in the upper right-hand corner. And this is almost like, I tell patients I love to look at their fingernails, and it's like a little window into what's going on with their blood vessels, because you can sometimes see the dilation of the blood vessels there, and that's very classic for dermatomyositis. In the lower right-hand corner, that is calcinosis in one of our patients, and so they sometimes these lesions, these calcinosis lesions, you can look like there, it all looks like it's ready to pop, and they'll actually sometimes extrude, and some of our patients will even sometimes push those lesions out. But we don't know for sure what causes calcinosis in dermatomyositis. It tends to be as the disease is burning out, so that tends to be a later stage thing than at diagnosis. So if you have a patient in your AI clinic that you were thinking, this rash just looks a little bit different than what I'm used to seeing. The patient's complaining of some weakness or some other vague symptoms. What are the things that you might consider getting in terms of starting a workup? So definitely can think about muscle enzymes, CK aldolase. Don't forget about AST, ALT. They'll be up in those patients too. Many times patients have had like a CMP for some reason, and we've had several patients ultimately diagnosed with dermatomyositis, but first sent to a liver doctor because they had a CMP and their transaminases were elevated, but it was coming from their muscle. LDH will be up as a muscle enzyme in these patients as well. Acute phase reactants, CRP, sed rate are sometimes helpful, sometimes not. I wouldn't think anything about a patient having a normal CRP and sed rate. That does not at all exclude this. And then you could start to think about getting some imaging of the affected muscle. So if you're at a place that could do ultrasound, that would be great. MRI is probably still the gold standard. And again, it's going to be the proximal muscles. So if they're having leg weakness, you probably want to get the hips and thighs. All right, and then I'm going to finish up talking about some of the skin findings in some of the other diseases that we treat. So Raynaud's phenomenon is certainly very common. I'm sure all of you see this in your clinic quite frequently. This is basically just transient vasospasm. And the classic is to have that 3-color change. So going from pallor, cyanosis, and then redness and pain as you're kind of like getting the blood flow back to your fingers. And classically, it has these lines of demarcation. So you can see towards the left there, that individual with that pallor. And what I try to ask patients is, do you know where it ends? Because they don't always have Raynaud's in office for you to be able to look at. If they do, that's great. Or oftentimes they'll have pictures. But for the patients that say, well, it's just my entire hand or just my entire arm gets, a little bit pale or gets a little bit blue or red or something like that, that's probably not going to be Raynaud's. It doesn't involve the entire hand. It doesn't involve the entire arm. There's typically going to be some demarcation. On the right, you can see that the individual, this is an individual with Raynaud's, and they tend to have more pallor. If their skin is darker, they'll just notice the pallor, and they're not going to maybe have the visible erythema, and so it definitely can look a little bit different. Primary Raynaud's versus secondary Raynaud's. So for primary Raynaud's, really no further workup is needed, and you can typically get at this by history in the clinic. So it's really just a benign, exaggerated vasoconstriction response. Typically, they're going to know the triggers for this. They're going to know it's when they're out in the cold, when they're drinking caffeine, when they're picking up a cold drink. Sometimes patients with Raynaud's have more symptoms in the winter, but oftentimes they can have more symptoms in the summer too. Or if they live in Florida, actually, they'll have more symptoms when they first are like walking outside and they walk into the grocery store and there's that rush of cold air. So being in the air conditioning can be a big trigger, going from the hot temperatures outside to the air-conditioned room. And it's relatively common, so up to 20% of women and 15% of men can have primary Raynaud's. Secondary Raynaud's, though, is that Raynaud that is associated with an autoimmune disease, and that's what you want to try to recognize. And that's going to be Raynaud's associated with things like scleroderma, lupus, overlap syndromes like mixed connective tissue disease, and these are the patients that have risk of ulceration. So these are the patients that when they get Raynaud's, it doesn't go away when they warm up their hands. If you look at their fingertips, these are 2 of our patients here, you can see that they have ulcerations on the tips of their fingers. So if they have Raynaud's and ulcerations, that is secondary Raynaud's. That is not primary Raynaud's, and that's not benign. So if you can try to take a really good look at the tips of their fingers and then also the tips of their toes, sometimes patients won't even notice that they have it there, but they can have ulcerations there. And so for primary, without systemic symptoms, oftentimes we'll try to look at the nail bed capillaries also, and this is from the ACR slide bank here. And you'll see in the upper left-hand corner, that's kind of normal nail bed capillaries. In the lower right hand, you see that tortuosity and indicative of vasculopathy. So if they don't have anything else going on, it has very known triggers, it's transient, they don't have any ulcerations, really probably they don't need any further testing. However, if they are having systemic symptoms, kind of based on your history, if you can see dilated nail bed capillaries, I would think about starting some initial evaluation, things like looking for screening for lupus, starting to screen a little bit for scleroderma. So you get CBC, sed rate, renal function for sure. You don't want to miss that in the lupus patients early on. ANA is a good, relatively good screening test if you can help the patient interpret it, and antiphospholipid antibodies. This is erythema nodosum. So we see this in our patients in a number of different conditions, but this is a paniculitis. So this is inflammation of the fat. And typically, if you were to run your hand over it, it's going to be tender, and it's almost going to feel like a deep nodule on their shins. And so these are examples in two different patients here. They can get this for a number of different reasons. It can be after an infection, so post-strep is a relatively common reason within the pediatric population to have erythema nodosum. It can be an early sign of inflammatory bowel disease, so they can have this even before they're diagnosed. Sarcoidosis, and then our favorite category in rheumatology of idiopathic. We don't know why you have it, but not associated with anything else. This is an example of livedo reticularis in antiphospholipid antibody syndrome. So on the right, that's kind of a very classic livedo reticularis. On the left, that patient has intermittent livedo, but also has these ulcerations from actually clots in his skin there. And so don't forget, when you see a patient with kind of severe livedo, especially if they're having any other symptoms, to try to think about antiphospholipid antibody syndrome. May or may not be associated with lupus. It could certainly just come on its own as well. So that was kind of a whirlwind tour of some of the rheumatology that you might see in the AI clinic. I wanted to just finish up with to talk for a few minutes about, as an AI physician, some of the rheumatology disease that is associated with the diseases that you treat with inborn errors of immunity. And so I'm going to be talking more about inborn errors of immunity in my next talk about immune dysregulation syndromes, but just a reminder, IEI, or primary immune deficiencies, comprise just a very large group now of over 470. Actually, I think we're over 500 now, single gene inborn errors of immunity. With a very diverse range of clinical symptoms. And so it's important to not think about IEI as simply infectious susceptibility, because that is certainly some patients, but patients with inborn errors of immunity have autoimmunity, they have lymphoproliferation, they can have bone marrow failure, susceptibility to cancer. This is from the IUIS, and they actually just, I think this week, published their updated report, so I'm going to have to update this slide, but this was the 476 inborn errors of immunity as of last year. And what they do is they break these up into different categories, and we'll be talking about some of these categories when we talk about immune dysregulation. But really, when you look at the names of those categories, it just highlights the very broad range of disease associated with inborn errors of immunity. And autoimmunity really it can be very varied in patients with inborn errors of immunity. So patients can have, if you look at this figure here, for example, they can have uveitis, they can have thyroid disease, they can have colitis, autoimmune cytopenias. So it can really take a number of different forms. I'm going to talk a little bit about the skin disease and a little bit about the arthritis, which we had started out one of our cases with. I would like to, and I know you can't read this, and I apologize, but you can hopefully look at your slides that you have. This is a great paper. I think this was just a paper kind of outlining all of the different rheumatologic disease that is seen in inborn errors of immunity in children. And they kind of broke up the diseases into different categories, but what to notice just on this slide as a big picture is they have these little figures for arthritis or vasculitis or lupus-like syndrome, and basically every category of inborn errors of immunity can have these different types of rheumatologic disease associated with them. This is just an example of some of the skin disease that that we can see in inborn errors of immunity. So some patients on the left here is a patient published in JACI by a group showing NLRC4 gain of function. These are infants that have an autoinflammatory disease. Oftentimes, the autoinflammatory disease will be neonatal onset, and so you're going to see that, for example, we've had patients diagnosed with cryopyrinopathies or CAPS, and they'll come in and they'll show us pictures of the infant basically on the delivery table with what looks like hives just covering the infant's body. And so those babies that are essentially born with a rash, you might want to think about autoinflammatory disorder. On the right, immune dysregulation syndromes, again, typically neonatal onset, tend to be a little bit more eczema, dermatitis, sometimes psoriasis. There's a picture there of of a case report that was published on STAT3 gain of function. It was an adult patient who had psoriasis, and you can see that. On the right is a picture of a boy with IPEX syndrome. That's a deficiency of regulatory T cells with very severe eczema. And then these patients with inborn errors of immunity can also get inflammatory lesions. So they can get autoimmunity, they can get typical, they can get hives, they can get typical eczema, psoriasis things, but they can also get these inflammatory lesions. And on the left here is a patient published by Succeed Deravine at the NIH. Who had hypomorphic RAG1 variants. So this patient didn't have SCID, and we'll talk a little bit about these kind of variants of RAG1 when we talk about immune dysregulation syndromes, but had this inflammation due to abnormal T and B cell selection. And you can see that this patient had midline granulomas that almost looks actually like a GPA type of a patient. On the right is one of my patients who has leukocyte adhesion deficiency, and she gets these very severe pyoderma gangrenosum lesions that are very slow to heal. And then not everything is autoimmune. And so just remember, in your patients with inborn errors of immunity, they can always fool you about what's going on. And so these are just a couple of case reports from the literature. On the left is a patient who had what looked actually like a photosensitive rash from lupus, and you can see that rash on her cheeks and on the nose there, but was actually a combined T and B cell immunodeficiency, and this was vaccine strain rubella. So this patient had had a rubella vaccine in the past and got these granulomas from that vaccine strain virus. On the right is a patient with MAG-T1 deficiency, and this looks to me like vasculitis. If you had shown me that picture as a rheumatologist, I'd say that's vasculitis, that's what it looks like. But this was actually an atypical EBV lymphoproliferative disorder. So just be careful with the patients with inborn errors of immunity. And then back to this case that we had started out with, where that patient was a 3-year-old girl who had presented with arthritis, had LRBA deficiency, and then ultimately went on to hematopoietic transplant. And thinking about arthritis in patients with inborn errors of immunity, it does tend to be polyarticular, so it involves multiple joints. It could respond to traditional therapies, but it tends to not have a lasting response. And so really in patients with inborn errors of immunity, you want to think about how that specific diagnosis could actually change their treatment for things like this, for arthritis. And there's just a little figure here showing you how when patients have a deficiency of LRBA helps actually to shuttle CTLA-4 to the cell surface of T cells. And so if you don't have LRBA, you can't get CTLA-4 to the cell surface. And that's why replacing that CTLA-4 signal with the CTLA-4 Ig, abatacept, can actually really help these patients. On the right is one of our patients with STAT3 gain of function who had very severe arthritis. And after we had diagnosed STAT3 gain of function, we started him on therapy specific to this. In this case, we used initially IL-6 receptor antibody because we know that's upstream of STAT3, and we knew his particular variant led to increased signaling upon activation. And he had significant improvement again with that personalized therapy. And just to finish up here, I'm thinking about key points for you as an AI physician in treating rheumatologic disease and IEI. Don't be afraid to treat the rheumatologic disease once you know that's what it is. And it may require what you might think of as immune suppression, but I try to think of it in these monogenic diseases particularly as immune modulation. For example, with STAT3 gain of function or STAT1 gain of function, giving a JAK inhibitor to those patients. Certainly some of those patients have an increased risk of infection, and so you want to think about the medications that you're using to give them. Is there any prophylaxis or things that you have to do with that? But don't be afraid to modulate their immune system using things like sirolimus and IPEX syndrome, PI3K gain of function disease. And then your expertise can really help the rheumatologist to feel comfortable with treating the disease and choosing the right agent. And again, if they're going to be giving a JAK inhibitor to a patient with STAT1 gain of function, maybe they should be doing some viral prophylaxis because we know that there can be reactivation of herpes viruses there. And then think about drugs to avoid. I pretty much never give an anti-TNF drug to any of my patients that have significant infectious susceptibility with an IEI. Never give a TNF drug to a CGD patient, so you can really help out the rheumatologist there. So just to summarize, rheumatology disease can certainly present to the AI clinic. Oftentimes it's going to be due to skin findings. These patients who have inborn errors of immunity, who have immune deficiency, can also present with a wide range of rheumatologic disease. And really that partnership in this multidisciplinary care for these patients is very important. And I'm happy to take any questions.
Thank you so much for the great talk. I have two questions, if I can monopolize the time for a second. One is, do you see livido reticularis? Can it just be benign? Like if they have burning and myalgias, but no inflammatory marker elevation, can it just be livido reticularis? Do I have to go barking up that tree a long time?
Yeah, no, it can certainly just be livido, especially babies, young children are going to have that, or if there's known triggers like they jump into a cold pool or something like that. But if they have that type of a livido that's fixed and it's not like related to temperature or other changes, I probably would think about at least looking for antiphospholipid antibodies.
What about pressure?
The other thing that you can think about, there's something called deficiency of ADA2, which is pretty rare, but those patients will have that too, and those are the patients that get strokes.
Right, okay. My second question is on the anti-TNF allergy range. That's a consult I've had a couple times in terms of reactions to their Humira or something like that. Do you have experience in terms of cross-reactivity between the anti-TNF agents, or if someone is having like hives and wheezing on one, is that primarily IgG mediated, IgE mediated? I've struggled with this. I've been able to skin test and re-challenge once, and another time we switched agents. But if the therapy is working, the rheumatologist really doesn't want to change it, and that really pushes me to try to challenge.
Yeah. I don't know the answer to that. I'm sorry.
No,
I will
that's
say,
okay.
like in kids, we pretty rarely see any kind of allergic reaction to TNFs. What we sometimes see is psoriasis, because it can be pretty severe, induced by TNF drugs. And in that cases, we're typically hesitant to start them on another TNF because there's a pretty high incidence of it reoccurring.
Okay, thank you.
Mm-hmm.
I'll be easy on one question. The urticaria guidelines have pretty much asked us to not do ANAs. Now, are you saying we should, because again, as you're right, we don't want to stick to kids more than we need to. So I stopped doing ANAs years ago. Is my sedimentation rate reasonable enough that if it's normal, I don't need to, and I may need to go back to it, or should I really start re-including my ANA?
No, I don't think you need to do an ANA on all the urticaria kids, but I think just taking a good history should be sufficient. So, are they having any joint pain? Are they having any chest pain? If they're having kind of anything else, then I would think about doing it. But I think certainly the incidence, as I highlighted, is it's very low with chronic urticaria.
Along that same line, your very first patient was a young lady who ended up with lupus, but her urticaria responded to antihistamines when she first presented. My experience has been, I'm supposed to think about something like lupus if they don't respond to antihistamines, because it's more of a vasculitic type problem. So, and vasculitic hives don't generally respond to antihistamines. So was it a true unrelated in that case, or do you think her hives were related to her lupus?
Yeah, and that was not my case. That was a published case from another group. I don't know. She had an ANA at the time. She was kind of in the right age range to develop lupus. But urticaria is a lot more common than lupus, right? So I think that you could certainly have both of those together and they could be unrelated. Yeah.